Okay, so moving on to our second topic for today, the impact of CML on pregnancy and fertility. And it's my great pleasure to firstly introduce Dr. Amma Anima Benneh-Akwasi Kuma from Accra in Ghana. Dr. Amma is a consultant hematologist, director and senior lecturer at the University of Ghana Medical School and the Ghana Institute of Clinical Genetics, and she is another great friend of the foundation. She is on the Foundation's African Steering Group. She is absolutely a tour de force at meetings and discussions. She was a contributor to our CML COVID case collection and is always there when I need to know something or I need to find someone in the African nations. So generous for the time. Amma, thank you very much for joining us today. And our international...
Thank you very much, Eileen, for the kind words.
Thanks for being here. And our international expert for the pregnancy topic is Dr. Elisabetta Abruzzese from the St. Eugenio Hospital and Tor Vergata University in Rome, Italy. She is a global leader in CML and pregnancy. Elisabetta is leading the way in achieving healthy pregnancies that balance the needs of the patient, the baby, and the disease. Welcome, Elisabetta. It's truly a privilege to have you here with us today.
Thank you for the invitation. It's always a pleasure for me too.
Amma, I can see you're ready to go. Thank you.
Thank you very much for the kind words of introduction. I hope you can hear me. And thank you so much, ICMLF, for your support and also the invitation to share some experiences. Thank you so much. So today we're going to look at the impact of CML on pregnancy and fertility. So our center is in Ghana, and Ghana is found in West Africa. And we have 16 political regions in Ghana. Now, the Department of Hematology is situated in Accra, Ghana, the capital. It is the largest tertiary hospital in Ghana. And we receive referrals from all the 16 political regions of Ghana and other countries in the West African region, such as Sierra Leone, Liberia, Togo, and Ivory Coast. Currently, we have 4 consultant hematologists, 4 specialists, and 8 residents in training. CML is diagnosed by morphology and molecular testing, and annually we see 15 to 20 new cases. Median age at diagnosis is 40 years, and currently we have over 200 patients on tyrosine kinase inhibitors. Our first line is imatinib, and we do have second line available, nilotinib, bosutinib, ponatinib. And this is through the JIPA program now, the Max Access program, and we cannot thank Max Foundation and the pharma companies enough for this. Now, tyrosine kinase inhibitors, without a doubt, have impacted significantly the quality of life and survival of people living with chronic myeloid leukemia. The natural desire to live life and live it to the fullest thus becomes a possibility, especially for people diagnosed with CML. The desire to have children becomes very important, especially in our setting. Cultural and social pressures to have children are very significant, leading to immense pressure to especially for the women to have children. Our fertility rate in Ghana, the 2023, it has even gone higher than this. It's about 3.6. And so that shows you how important pregnancy and fertility issues are to the population, and more so to those living with CML, who are no exception. Most of our patients are in the reproductive age group. At diagnosis and before treatments, contraception is emphasized among women. Pregnancy is thoroughly discussed. In spite of the several counseling sessions, pregnancies occur, and thus it becomes a journey embarked on by the physician and patient to ensure the survival of both mother and child. So once the person is pregnant, what happens? The tyrosine kinase is stopped immediately. Patient is monitored monthly with full blood count. Watch and wait, as we call it, but monitoring. And so we monitor the full blood count every month, looking out for conditions to start hydroxyurea, which is our only option in pregnancy, the treatment of chronic myeloid leukemia. So we're looking for a total white cell count of more than 100 times 10 to the power 9. We're looking at the clinical condition of the patient. And usually, even if there's going to be any intervention, it starts during the second trimester, after consent has been given by the patient. After delivery, there's no breastfeeding, and tyrosine kinase is restarted as soon as possible. Interferon, which we know is used in pregnancy, is not available to us in our center. So the challenges, we have cultural and social pressures to have children being the biggest challenge in our environment. Then availability of other treatment options apart from hydroxyurea, and even with the hydroxyurea, affordability. Breastfeeding also becomes a challenge. There's that natural desire to breastfeed your child. And after that, you'd also have to contend with the campaigns done by our pediatricians and, in fact, all doctors on the advantages of breastfeeding. So trying to encourage new mothers, especially, that they cannot breastfeed becomes a challenge. Ultimately, you'd need somebody to be in deep molecular remission before getting pregnant. However, in the cases that I'll share, you realize that this is not the case, and that is also a challenge. So these are a few challenges that we have. So going to case 1, we have 35-year-old Ms. R, who presented with a 2-year history of abdominal mass and 2 months history of easy fatigability. Ms. R is married for 5 years and has a son. Significant findings on examination were anemia and hepatosplenomegaly, 18 centimeters and 15 centimeters, respectively. Diagnosis was made by morphology and by molecular reverse transcriptase PCR, that's the gene aspect, and the transcript level was 66%. Gleevec was started. The initial full blood count, the hemoglobin was 8 grams per deciliter. Total white cell count was 350 times 10 to the power 9 per liter, and platelets was 700 times 10 to the power 9 per liter. Gleevec was started at 400 milligrams after counseling, which included a discussion on contraception and pregnancy. Patient attained hematological remission after 3 months and major molecular response after 8 months. She, however, presented with a 2-month history of amenorrhea after 18 months of therapy. Pregnancy was confirmed. Full blood count at that time was an HB of 12.5, a white cell count of 6.5 times 10 to the power 9 per liter, and platelets of 350 times 9 per liter. Gleevec was withheld, patient cancelled and enrolled in an antenatal clinic. She was asked to come for monthly reviews. She, however, came only for 4 reviews before delivery. Her last visit was the 8th month of pregnancy with HB of 10.8, white cell count of 15.3 times 10 to the power 9 per liter, and a platelet count of 500 times 10 to the power 9 per liter. So hematological response had been lost. Her next attendance was 3 months after delivery. So this just shows us the full blood counts on the review dates that he was able to come. Quite stable till the 8th month when he appeared, having missed the 7th month with leukocytosis and thrombocytosis. So when she returned after 3 months of delivery, her full blood count was 9.4 HP, white cell was 55 times 10 to the power 9, and platelets 600. She had a splenomegaly of 5 cm. She was cancelled again to wean the child and returned the following week to start Gleevec, imatinib. Fortunately, she did. Imatinib was restarted at 400 milligrams, and she went into hematological remission after 2 months. Thank you. So that's the first case.
Do we want to start the discussion?
Yes, if you could pick up on some of
just
those.
after the first case?
Yes, if you can have some discussion about the first one, and then we'll move on to the second one and a general discussion.
Actually, I need to, okay. There are no questions now in the chat. Let me kind of recap a little the interesting case that Amma presented. And let me say that one important thing came up, that at diagnosis, you start talking about pregnancy and the need to enter into remission before starting pregnancy. And the social pressure is important. And also the age of the patient is important. This was a patient that was 35 years old. She kind of only had 1 children only. And so she probably wanted to have another child. So you have to face 2 possible scenarios. One is a planned pregnancy, and another one is an unplanned pregnancy. We don't know exactly if she was in major molecular remission. I think I didn't catch up from the presentation. She was treated for 18 months. She was certainly in complete hematologic remission, and probably also in cytogenetic remission, but there were no information about the molecular and the cytogenetic status of the patient. Just one question for Amma. You check the SOCAL or any other score, because also the kind of a biological risk of the CML must be taken into consideration, Amma.
Yes, we try and do it for every patient, and then we also do the UTOS score as well.
Okay.
So we do have that. And then this patient was in, I think, major molecular response.
Okay, great. Great. But you didn't check the molecular response while on pregnancy after she stopped treatment, correct?
No, we didn't. Costs, and sometimes that becomes a barrier because they are paying out of pocket. So,
okay.
In the first place, they have a challenge when they are pregnant to come because they are afraid you're going to tell them you're going to put them on medication. And so when you add an additional cost, although this is heavily subsidized, sometimes it prevents them from appearing at all.
Okay, because in the ELN and the GMEMA database, we have quite a good number of patients that were treated with imatinib. After the placenta was formed, we thought that it was much better compared to hydroxycarbamide, and this is a drug that they have access to. So this is something that in the future could be taken into consideration. And even if they also, even more, if they don't come often to be checked, this is something that can be important. And I was asking why she was not placed into imatinib right after delivery, just because she didn't come to the controls, because they said that after delivery the control was planned 4 months after, or maybe because she was commuting and too far from the hospital.
Yes, it's all about compliance, and that's where the breastfeeding challenge comes in, because they know that when they come, we're going to tell them not to. And we've always been advocating for breastfeeding, so that also becomes a challenge. Please, you did mention something about 4 months. I didn't quite get it.
I think in the slides it was written that she had a control plan 4 months after delivery. I probably miss.
She appeared 3 months after delivery, and we talked to her again.
She did.
Yes,
okay.
she did. Yes.
Okay.
Yeah.
Okay,
did.
because she had lost the complete hematologic remission at this time.
Yes.
And she regained molecular remission anyway after restarting treatment.
Yes.
Okay.
Yes.
One other thing that can be interesting is that Carlo Gambacorti has done a check on the breast milk excretion of imatinib components, and he kind of evidenced that the concentration of imatinib into breast milk is the same concentration of the plasmatic level. So it's actually 10 to the 3 or 10 to the 6, I don't remember, times less than the oral administration of imatinib. Thus, he was concluding his paper, saying that it's not worth it withholding the breastfeeding of women treated with imatinib because the concentration is neglectable as consequences if used for a few months in a baby that is growing. So we kind of suggest that we have an alternative, and so you cannot breastfeed and use the artificial.
Oops, Elisabetta has frozen. Elisabetta, you're back. Great, thank you. If you could just finish what you were saying, and then I'll invite Ahlam Nasser to come with a question, please.
Sure. So the first two of the points is that imatinib can be used after the placenta is formed, meaning after the 16th to 20th week of pregnancy. And the second, that breastfeeding could be done while on imatinib because the concentration in the milk is neglectable for the baby. Okay, but I couldn't see any question.
So Ahlam Nasser, would you like, sorry, we've kind of moved into some general questions now as well, but it's a great question. So if you could ask your question, and then we might just segue into the second case, if that's okay.
Thank you so much for the opportunity. So maybe from the previous question, maybe to get a clarification. So it is okay for the patients who are on imatinib to continue breastfeeding?
Yes, because the concentration of imatinib in the milk is very, very little, because this is the same concentration that you have in the plasma. So the regular concentration is I think is 1 milligram. Okay. So 1 milligram is not the 400 milligrams that you're taking.
Okay, thank you so much. So my second question was on regards to how can you approach a patient, a female patient who has not or has lost a hematologic response, but then at presentation or maybe at a follow-up clinic shows up pregnant, maybe 2 months pregnant. So I think this is a part of the dilemma that we keep facing, especially in the context of unplanned pregnancy. So how do you advise this patient? And we are dealing with a lot of young ladies, because our mean age of diagnosis is around 40 years, which is quite low compared to what is seen in the West. So how do you approach such a patient? Thank you.
Amma, do you want to answer, or you want me to answer, or we can answer both?
Please go ahead.
Okay.
Yeah. Okay,
so if you have a patient that is pregnant in the first period of her pregnancy, and she has to stop treatment. Usually we stop treatment between the 5th week until the placenta is formed, because after that the organs are formed. And so the major risk that you have with imatinib is of malformation. And it's true that it's not 100% of patients that present malformation, but if you have a percentage that exceeds the normal percentage, that is around 3%, and here we're dealing about 15 to 20%, it's better not to advise the woman about pursuing imatinib. We intervene when white blood cells count are above 100,000 and or platelets are above 1 million, because those are the kind of a dangerous level, especially when placenta has been formed. So we can assume, but we are assuming, since you cannot use interferon, that you could lower the white blood cells in this critical moment of the organ formation, either with leukapheresis, with a short period of hydroxyurea, or waiting the 16th week and start imatinib after organs are formed, specifying that the earlier you intervene with TKIs, the more a little dangerous is. I don't know if I answered your question, but now it's a question of common sense, and you need to talk to the patient. Basically, if they are there discussing with you that they want to stop the pregnancy, and so you need to give all your knowledge to consent that she could keep on with her pregnancy. And hydroxyurea is one solution, imatinib after the organ formation, and ideally after the 16th week of pregnancy, and leukapheresis at the beginning. You can wait until 100,000. Actually, the main problems are after placenta is formed, because it's there that you have a high white level count and high platelets. You have more risk of thrombotic issues. And of course, you cover with aspirin. I don't think you have problem having that.
Thank you. So if I got you correctly, so if in case in the first trimester and then the white cells and the platelets are too high in the limits that you have mentioned, it is safe to proceed with hydroxyurea rather than imatinib, right?
It's better hydroxyurea than imatinib because it acts very quickly and it has a lower teratogenic potential, even if it's an alkylating agent. So you know that the malformations are a multifactorial problem. So you never know if you're using a drug, if it will give you problems or not. On 100 patients, you will have 80 that do not have any problem, 5 that have some problem, and 15 that have serious problems. So
I might invite
information is first. Inform the patient and then you go ahead.
Okay, thank you.
I might invite Amma Benneh to comment on that, but I'll also throw into the mix another scenario which Amma Gebremehdine has brought up, which is, what about a patient who is pregnant and is diagnosed with CML during pregnancy? So we might have a respond to Professor Amma Gebremehdine and then definitely move on to Amma's second case. Otherwise, we'll have lots of interesting questions and never get to the second case. Amma, would you like to comment first on both of those scenarios?
Yes, thank you. So for us, during the first trimester, we don't give anything. Fortunately, we haven't gotten to the 100,000 times 10 to the power 9 level during first trimester. We've been lucky so far. So normally first trimester, we don't give anything. Now, we did have a case, but fortunately, it was third trimester, newly diagnosed lady with splenomegaly white cell count. It was in the third trimester. So we just did weekly full blood counts, delivered, encouraged him to stop breastfeeding, and then start her on imatinib, and she's done very well. The child is also doing very well. So it also depends on the stage, you know, at which the person gets diagnosed, and then we take it, we treat it as our protocol. So that would be my comment. Very helpful information on the breastfeeding, because when things started, breastfeeding was a no-go area. So thank you so much.
Very quickly, I can say, adding to Emma's information, that there are two papers. One is published, the other one hopefully is going to be published soon. The first is on therapeutic advances in hematology that should be open access, and it's a pregnancy recommendation and done by a group of people working on this subject, including me. And there's a table that suggests what to do for each trimester depending on the burden of CML. And so this could be kind of helpful. And the second thing is that for the patients that are diagnosed with CML during pregnancy, it's the same thing we just discussed, also the same for who lost complete hematologic remission. And a paper has been submitted with 87 patients diagnosed during pregnancy. Hopefully in a month or two, if it's accepted, you will find it online. And thank you for this question. I know it's an important question and a little challenging issue.
So the second case, 28-year-old female presented with a 9-month history of abdominal distension. On presentation, she was noticed to be mildly pale and had a tinge of jaundice. Both liver and spleen were 18 cm palpable below the costal margins. Other systems were essentially normal. She had been married for 2 years and was yet to have a child. Full blood count on presentation, hemoglobin was 7.7 grams per deciliter with a white cell count of 500.22 times 10 to the power 9 per liter. Neutrophils was made up about, the absolute neutrophil count was 440 times 10 to the power 9, and platelets was 308. She was started on hydroxyurea until counts were low enough for the BCR-ABL. This is what we do at our center, because what we have is the GeneSpect platform, which ideally should be used for monitoring. But because we do not have access to regular PCR or cytogenetics, we also use it for diagnosis. And the counts have to be below 100 times 10 to the power 9 before we can use it. So this was that she was started on hydroxyurea and presented, she was diagnosed, and then imatinib was started subsequently. She then presented 5 months with amenorrhea, and hematological remission had been achieved though. The pregnancy was confirmed and cancelled, and she was cancelled, and she appeared 4 months postpartum, fortunately still in chronic phase. Therapy was started after breastfeeding was stopped. So I just want to conclude that the burning desire to have children in our part of the world is very real, and people living with CML are no exception. There is an urgent need for education and frank conversations at diagnosis, especially in societies where influence of cultural and social pressures are profound and treatment options during pregnancy are limited. The need to be in molecular remission, major molecular remission or better, cannot be overemphasized, especially in an environment with limited treatment options during pregnancy. It is a journey that has been made, that has to be made together by the physician and patient, with collaboration with the obstetrician to achieve a successful outcome. Thank you so much.
Yes, well, this is a case in which is not really clear when she discovered to be pregnant. You said 5 months after starting treatment, but at which week of gestation do you kind of discover that she was pregnant? I mean, do they keep track of their cycle or not?
As you well know, women always try to keep track of it, but sometimes they get surprises. So for this particular one, it was a surprise.
Okay. So you may discover after the 5th week of pregnancy.
Yes, and so when we have that, we normally ask for an ultrasound immediately. And that kind of gives us an idea.
Okay, of course. To identify the age of the baby.
Yes.
Well, I think that those two concepts that we exported today about either breastfeeding and the possibility to use imatinib after, I'd say, the 16th, 20th week of pregnancy can be of an important point for populations that do not have access to interferon or do not have access to timely and frequent screening for response to treatment. And if you agree, I can recover those 2 papers and send it to Arlene, and Arlene can send the full paper to the full manuscript to all of you. And one more thing, if you think you have patients that you want to refer to the international registry, the ELN registry, please feel free to do it. Arlene can give you my email address, and I can give you the password to access the database. And we are now finishing to exporting the Italian database, but I think in February we will start working on the ELN database. It's very important that we can receive information to picture what happens not only in the country, in the European countries, but all over the world. And Africa is an important oh my God, continent that we would like to join our registry. It's very important, and it's nice to see how many dedicated people are present.
I love the sense of collaboration that often comes from these meetings. And Ahlam Nasser, someone has found a hand. Well done. Please ask your question.
Mine is more of a comment regarding what Dr. Amma has highlighted in terms of the difficulties they have with the gene expert when it comes to a lot of white cells. This was a common scenario that we had encountered during when we were trying to establish BCR-ABL testing for our population. It's because our patients from African continent, we see that they present late, and therefore the white cells is very much elevated. So if you use the protocol of 4 meals of the gene expert, you are definitely going to get error. And I think that must be the issue that they're facing. So what we had discussed this with the CEFED regarding the kids. And so the recommended protocol, when you have elevated white cell count, instead of using 4 meals, which is in the protocol, you have to use 10 microliters. So if you use 10 microliters, it doesn't matter how much white cells the patient has, the BCR-ABL is going to give you the results. So using a very much reduced volume. So this is like, basically you'll be using the protocol similar to when you're analyzing the bone marrow rather than when you're analyzing peripheral smear. because with the packed white cell, it's more like you're seeing the bone marrow rather than the peripheral smear. So I'll recommend them to try with the 10 microliters, and I'm happy to share the protocol that we had concurrently had with the Cepheid, which is able to process such type of samples. Thank you.
We dilute the
Thank you so much. You
we
know, we
dilute the
started doing BCR probably 2013. And over the years, also with feedback to Cepheid, the kits have been modified, because I think initially it was more for monitoring. So we weren't expecting these high levels of WBC. So thank you so much. We'll do that. At some point, there was this reduction, but at that time, I think we weren't dealing with the standardized. So I'm happy that things have been done, because through that we have evolved what we use, and it would be nice to see what you are also doing with Cepheid. So thank you so much. And we are very happy to collaborate, Elisabetta, to get into the database. I think
Great.
Oliver also mentioned about telling our story. I must say that if you're practicing in Africa, getting the story out there is very difficult, because we do not have all the current equipment and technology. And so we have the basic stuff, and sometimes journals are not interested in just the basic stuff. But it is a challenge, and I'm hoping that the journals will be sympathetic to the fact that we do not have all the current sophisticated equipment, but we do have stories to tell. Thank you.
But it's important to register what you are doing with what you have, because you cannot tell the world to use NGS single cell if not everybody uses that. So it's very important to picture what happens all over the world and how those ladies are doing with different approaches. Probably it could come up that just maintaining the complete hematologic remission is enough. That is probably true, because we're not dealing with acute leukemia, we're dealing with chronic myeloid leukemia. So it's important to have information. Thank you.
And that's great. Thank you so much. Amma, do you want to make one final comment before we draw it to a close? There's always so many interesting questions and so little time.
Oh, thank you. I think it's been interesting. And again, we've learned so much. Thank you, ICMLF. Thank you, Elisabetta. Thank you, everybody, for joining. And please, let's keep the conversation going. Thank you.
Sure.
Absolutely, absolutely. And goodness, that last hour and a half just disappears. So thank you so much, Dr. Amma and Dr. Elisabetta, for such a lively discussion. And thank you to the audience members again for getting involved, for your questions and your comments. It makes such a difference to have some active involvement. And yes, the sense of collaboration that comes from these meetings, you know, let's make sure that we capitalize on it and don't leave it on a Zoom call. So again, I think we covered all the questions on the chat this time. If not, we'll go back and have a look. If we missed something, I'll try and get a response for you from Amma or Elisabetta. So we hope to see you all again soon. The third scheduled African discussion will take place on Wednesday, the 27th of December, same times as today, where the topics will be the wide-ranging challenging scenarios in CML treatment. And again, there's a great team of experts leading those discussions. Please join us for it. I'll send links for registration and so on soon. And we hope to see you online too. And if you aren't already familiar with the ICMLF Knowledge Center, I'd strongly suggest that you go and check it out. There's literally a wealth of knowledge in there with dedicated modules on TFR, from the laboratory, pediatric CML, management practicalities, etc., etc. Michael Lusink, who was our international expert for the pediatric section, does a fantastic section in the pediatrics, along with all her other colleagues there. And I have to say that the pregnancy module is sensational. Amma co-chairs that module with Professor Jane Apperley from London, and Elisabetta does 2 absolutely sparkling presentations. All the scenarios that were mentioned, so many different possibilities with very clear direction, comes through so clearly in her presentations. Please go and have a look at them. They're just great. If you want to keep up to date on what's new in CML, please check out our website, sign up for the ICMLF newsletter, and we'll send you papers of the month, including, for example, ones which Elisabetta just mentioned. We can keep you up to date with upcoming meetings, webinars, links to summaries of conferences and discussions. And also via the website, you can engage with our interactive case discussion forum, where we take difficult or interesting cases to the key experts in the field for advice or for commentary. Or you might like to join our social media outlets, Facebook, Instagram, Twitter, whichever you prefer to engage with. So, okay, that's it from me. Thank you very much for being a part of this discussion. And I hope we can do it all again on the 27th of December. Thank you very much for your time. Absolute pleasure.